Okay, hi guys. I'm back after a long time with a new video, and this time the lecture or the tutorial, if I might say so, is on approach to myeloproliferative neoplasms. And the first MPN that I'll be discussing in brief with you is CML. I have taken a long time to come back due to some bad health issues, and I couldn't get time. I have a lot of work these days, but I'm trying to at least upload one video in 15 days. So please bear with me there. And this is a 10 to 12 slide video. Now, some of these tables, etc., from the book, my book that I have published, Manual of Hematology. I'm going to show the book to you in the end. This is available. If on Google you go and type Manual of Hematology and my name, it is published by Ahuja Publications, and this is available. It is just 188 rupees these days, so you can go and order. And please tell me whether you liked it or not. Soon we'll come out with a benign hematology part also. So without wasting much time, let's move ahead. So we all know that chronic myeloid leukemias are a part of something known as myeloproliferative neoplasms. And in WHO, the chronic group has, or the proliferative group of neoplasms, the chronic proliferative group has two, either it is MPN or MPN MDS. That is myelodysplastic syndrome with MPN or just myeloproliferative neoplasms. Chronic myeloid leukemia, the classical chronic myeloid leukemia is divided, is very distinctively known by the BCR ABL1 positivity that it shows, the translocation 911, which is very classical for a classical chronic myeloid leukemia. Then there are certain atypical variants of the same thing. Then comes chronic neutrophilic leukemias, chronic granulomatous leukemias, and Philadelphia chromosome negative types. So today mostly what we'll be dealing with is the classical BCR ABL1 positive. So when a patient comes to you, if I talk about the approach, the patient might, now CML is one of the most indolent kind of leukemias in its chronic phase. Patient will either complain of fatigue or lethargy, or might have a massive or a moderate or even a mild 2 to 3 centimeter below the subcostal margin spleen, and he will categorically complain of a heaviness or a dragging sensation in the left hypochondrium, and that is very classical for a case of CML. Other very rare presentations can be penile erections, multiple penile erections can be there. Then some thromboembolic phenomena. The count is very high due to stasis. Those kind of priapism is one of the causes. Symptoms similar to priapisms can occur. Skin changes can be there. So, but the most common presentation of CML is a dragging sensation in the left hypochondrium, that is splenomegaly with fatigue. Okay. And the phasing, so this is how the patient presents to you clinically. And when the patient presents to you, the first thing that you go for is a CBC, and the clinical examination tells you there's a spleen, so you don't need to go for an ultrasound examination. When you go for a CBC, you will mostly see a near normal platelet count and a WBC count above 1 lakh. Okay, and that is very classical for a case of CML. Hemoglobin will be mildly deranged. So I have seen, okay, there's one more taboo that we have, that CML occurs in mostly old age. I have seen cases as young as 12-year-old male child getting CML. So I think that thing is changing, and even the book records it, the WHO records it, and with time, this thing that no CML only occurs in adults will change. So when you have made your diagnosis, it's a very clear-cut thing, clinically very classical, CBC is very classical. Then you go for the peripheral smear examination. Now CML for peripheral smear examination is divided into three phases. There's a chronic phase, an accelerated phase, and something known as a blast crisis, which is similar to an acute leukemia. Normally, we don't advise a bone marrow in CML because the PS is full of suggestive cells, until and unless you are suspecting a very overlapping of some other, like an MDS or something with CML, or if there's a blast crisis. or you're not clear about the phasing, then only. Otherwise, peripheral smear is enough to send a RT-PCR and make your diagnosis and start imatinib, which is in nowadays second line tyrosine kinase inhibitors are there, but I'm going to be referring mainly to imatinib because that is what was used most commonly. Okay. So what happens in chronic phase is that you are going to get all the mature myeloid lineage cell, like you'll get a myelocyte, a band form, basophil, but you'll get more number of basophils as you see in a normal smear and more mid-series myeloid lineage cells than polymorphs. Having said that, and after following the WHO criteria, we have also seen cases, reported cases practically, where you see more of polymorphs in a count which is around 1 lakh, and you might think it's a leukemoid reaction. Then what is the most basic test that you can use? There's a stain, and that stain helps in doing what is known as the LAP score or NAP score, that is neutrophil alkaline phosphatase score or leukocyte alkaline phosphatase score. What happens is in all these neutrophils and WBCs there are granules. As the myeloid lineage matures, the granules acquire enzymatic activity, and in the more mature the cell, more enzymatic activity is there. Less mature the myeloid cell, less activity is there. So if you do the scoring and around 80 to 100% cells are showing that stain, taking up that stain, so it's mostly a leukemoid reaction. If you do the scoring at this staining is decreased, the score is I think below 40, then it is a chronic myeloid leukemia. This is a very basic way of understanding this. However, nowadays you have RT-PCR for BCR-ABL, you have cytogenetic evaluations. So things have changed. So this is a table, this is from the book, where as I said, the leukocytosis, initially we used to take it as more than 1 lakh, now we do it as more than 80,000. And then children show greater degree of leukocytosis as compared to adults. So as I said, WHO documents the fact that children also suffer from CML. Persistent increase in TLC so now what I've done in my book is, made a table to compare. So TLC can be around 80,000 to 1 lakh in chronic. It will be more than 1 lakh in accelerated, and in blast crisis there can be any TLC. You will see clear cut blasts. Clear cut blasts. Very few mixed middle series cells, mostly blasts. Then of course DLC will show you all the myeloid bulge lineage, but monocytosis is less than 3%. Keep that in mind because CML needs to be differentiated from CMML sometimes. Okay. When greater than 20% basophils in accelerated phase and greater than 20% blast in blast crisis. Blast and smears in CP is less than 2%, 10 to 19% in accelerated phase and 20% से ज़्यादा है in blast crisis. Coming to bone marrow, mostly you don't need to do it until unless phasing is confusing. The treatment for accelerated phase is similar. You don't need to do much except monitor. If it is early accelerated phase, if it is going towards blast crisis, you treat it as an acute leukemia. All right. So mostly, and the current WHO differentiates these phases based on the response to treatment also. Supposing the bone marrow is showing you morphology of a chronic phase, but the patient is not responding to imatinib, or the load of BCR-ABL mutation is not decreasing, then there's no molecular response, there's no cytogenetic response, that you will grade it as accelerated irrespective of whatever features you are getting in the bone marrow. Okay. So there's an overlap, an interplay of all these three findings to decide what the actual stage is. So marrow is hypercellular. There will be a myeloid blast. In chronic phase, the blast would be less than 5%. In accelerated, there will be more basophilia, and then more than 20% blasts in blast crisis, which can be lymphoid, myeloid, monocytoid. It can mimic anything. Okay. A most important thing are two things: dwarf megs and pseudo Gaucher cells. When there's a lot of turnover of cells in a highly proliferating marrow, then the macrophages eat up the turnover is increased, so the nuclear remnants and the cytoplasmic remnants of dying cells, and as well as actively immaturely being cells being immature cells being produced is there too much. So macrophages keep eating all these dying debris cells up, and उसी वजह से एक pseudo Gaussian appearance आती है as if there's a pseudo store itself. Apart from that, you'll get dwarf megs, not micromegs. Dwarf megs have a mature, like a granular cytoplasm and a lobated but a small, kind of a nucleus. Micromegs are unilobed actually. and mostly what I have seen from my practical experience, they are eccentric but unilobed, not this kind. And this is a feature of MDS. This is a feature of CML. Okay, bone marrow biopsy might show fibrosis. In pre-imatinib era, when hydroxyurea was given, fibrosis were a poor prognostic factor, but not now. It doesn't matter now. Molecular, we need to know what exact point mutation is happening in this BCR ABL 911 translocation. So if that point mutation is at the P210 region, it is a common, very very common in CML. If it is at P190 loci, it mimics CML and it is also seen in ALL. So remember, for CML it is translocation 911 P210. Okay. Then accelerated phase may show other clonal chromosomal abnormalities in pH positive cells, including trisomy 8, isochrome 17, trisomy 9, complex karyotype, and any new chromosome. And if there is any other chromosomal abnormality occurring after drug therapy, all that is accelerated phase. Then blast will show you multiple breakpoints like BCR B1, B5, exon 12, 16, P210, mu BCR, C1, C2. These are all the breakpoints which you should know for competitions actually. Mostly you need to remember P190 and P210. Okay. Organ involvement spleen will be enlarged. If the patient is taking TKI and molecular response is not there, spleen might not be there, but still the patient will be in accelerated phase. And massive splenomegaly, then the markers for myeloid are 33, 13, KIT and MPO, that is CD117, c-KIT, and blast it is CD34, or if it is a lymphoid blast crisis, then you go for the lymphoid markers. Okay, all this table is given in my book for every malignancy. This is just CML, but these tables are given in my book for every malignancy, and these are made from WHO and recent advances. So treatment, I told you, first generation is imatinib, then these days dasatinib, nilotinib is there. As you progress, people are now looking forward to stem cell transplants as treatment modality. Fine, and but there are certain, like there can be a provisional response to TKI criteria, and on based on this provisional response, we can label something from CP to AP. There will be hematological resistance of failure, or there can be a molecular or cytogenetic failure. There's no response to any two TKIs, or occurrence of two or more mutations in BCR-ABL. Blast crisis is treated as leukemia, and it does not have a very good prognosis. So what are the practical tips? Chronic phase CML can be missed due to mild symptoms. It has a good clinical course, the chronic phase. Various levels of mutations can be there. I've shown you various breakpoints, B1, B4, etc. TKI responds very well. Side effects of TKIs are mostly skin rashes and GIT complaint. In AP, it might progress into blast crisis. So it is important to keep in mind that if lymphoid blasts are seen in very few numbers, it has to be considered bad, because lymphoid blast crisis progresses more quickly than myeloid blast crisis. Patients diagnosed as in accelerated phase might have same response as patient diagnosed in CP. However, those who progress from CP to AP will have a poor response. What it means to say is that when you diagnose something at AP and stop it there, it is better. And if CP is progressing to AP, then your treatment is not working actually. So you need to go for a higher treatment, or follow up the patient. So then the prognosis deteriorates. Also, since it's a myeloid lineage neoplasm and the myeloid is mutating from its chronic phase to its acute leukemia phase to give a lymphoid blast, hence lymphoid blast crisis is poorer prognosis than myeloid blast crisis. That is what these two paras mean to say. So another table, what are the various types of MPNs that you can encounter? That was just for CML. So there will be BCR-ABL negative, that can be CNL, CEL, basophilic leukemias. Then there will be ET, PV, myelofibrosis, and MPN unclassifiable. Normally BCR-ABL positive is CML. Then you go for some other mutations like JAK2, MPN, JAK2 and CALR mutations for these entities given over here, which I'll slowly take up as I move ahead. Okay. Again, just to show you what happens, that you see a red over here, 9Q and a 20Q11 and DCR. I have been saying 911, I think it's 922, I'm sorry. Fine. So what happens is there's this piece goes over here and this piece goes over here, and this kind of a Philadelphia chromosome is created over here and over here, and this is known as translocation 922. And over here there are breakpoint regions which have over here and over here. There were regions at which this break took place, and there were alleles over there. Those alleles are labeled as P210 and P190, and then within those alleles there are regions where the break took place, and those are known as B1, B2, B3, B4. Okay, again a picture to show you. You'll get myelobasophils, you'll get dyspoetic, maybe mild dysposis is there in CML, but you'll get all the three lineages. You see, you'll get every lineage and you'll get some basophils over here. Okay, you might get monocytes, but they'll be less than 3%. So this is how a CML looks. Platelet count can be near normal. So what are the responses when you go ahead with CML diagnosis and treatment? You need to look at hematological, cytogenetic, and molecular response. It can be complete or incomplete or partial. So hematological response is to see whether the blood counts have returned to normal, whether there are any blasts or not, any other signs or symptoms. Okay. Then comes cytogenetic response, which can be complete, that is no Philadelphia chromosome. ठीक है, and by fish you send the bone marrow for cytogenetics. Partial is 1 to 35% of cells show Philadelphia chromosome mutation. Major is 35% or fewer cells have Philadelphia chromosome, and minor is more than 35%. This is cytogenetics done by fish, the chromosomal analysis. Molecular is the after when you see the chromosome through fish, then you through RT-PCR try to see what exact mutation took place. So that BCR ABL1 mutation उसमें कितना reduction हुआ है. बेसिक एक कट ऑफ हम लेते हैं 3 log reduction. अगर 3 log reduction हुआ है then it is a major molecular response. नहीं हुआ है then there's a and if you can find no BCR ABL mutation at all, then it is a complete molecular response. अगर 3 log से कम reduction है then it is no response, partial response. Okay, and important point is this, ठीक है, T3151, because imatinib resistance occurs when there is mutation in this protein over here. In such cases you need to upgrade to dasatinib, nilotinib and other features, and they are poor responder. It is a poor prognosis if imatinib is resistant. Okay, differentiating features between CML, all this is there in the book. CML, CML and atypical CML. So leukocytosis can be there in every case, mild to moderate differentiating. Monocytosis is more in CMML. ठीक है. Basophilia is and immature granulocytes are more in this CML. Granulocytic dysplasia is more in atypical CML. So no, not much basophilia, not much monocytosis, but granulocytic dysplasia. Blasts will be more in atypical CML, less in CML and CML. Erythroblasts will be seen in CML because there is dysplasia. It is MDS MPN. And then of course features favoring CML and PMF, more fibrosis, less of dwarf megs, megakaryocytic hyperplasia, and a change in location of megakaryocytes. They're more paratrabecular, favors other things rather than CML. Okay, this is my book. Please buy this. Most of these tables are there, and for every malignancy of hematology, lymphoma, leukemia. And please review this and tell me whether you like it or not. And I hope I'll be able to upload during Holi again. That will be histopathology of lung benign lesions. And till then, take care and hope to see you next time.